Well, here's the thing. I have also rolled my eyes, at Bob
Absolutely.
who comes in, right?
Absolutely.
But what I've learned to do is to say, "Oh, I'm rolling my eyes." That means I have to really have like some laser focus because I am at risk of missing something because of my own blinders, my own bias.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey, everybody. Thanks for joining me again this week on the podcast. A couple things before we get started. I want to give a quick shout out to a couple people who left reviews for the podcast this week. Let me just quickly read you one of those reviews. This show is a constant reminder of why we do what we do. It makes me feel not so bad feeling the way I feel sometimes. As an ER nurse, we're a different breed, but still so much alike. It's refreshing to hear how we question ourselves at some point about the same things, and that times that we've all been through the same experiences that have changed us. I just want to say thanks to you, the person who left that review, always an ER nurse. Thanks for leaving that review on iTunes. I appreciate it. The next bit of feedback came in through the email inbox. The feedback says, "Great podcast. Kevin, you're a badass. Thanks for picking people who really have an impact on emergency nursing." Well, Jenny Mick, thank you for that feedback. I appreciate it. Thank you for listening. And I passed that feedback along to Lisa Wolf, and she got a chuckle out of it. If you want to leave feedback, there's a couple ways you can do it. You can always use iTunes to leave a rating and review. We always suggest that. And you can also email me at kevin@artofemergencynursing.com. I'd love to hear your feedback on the episodes and the guests that I have on. For this week's episode, I'm continuing the call with Dr. Lisa Wolf, and she has even more value to provide. If you liked last week's episode, you're going to love this episode. Enjoy. And again, please give me feedback if you have any. Thanks so much. Enjoy the episode with Dr. Lisa Wolf. What's the best advice you got from a mentor?
So well, two things. One, I think, was my first preceptor in critical care, who was like, chart like a lawyer. Right? Imagine that you're going to be reading your notes 5 years from now and defending your actions in court. And I was like, okay. So I learned to write a really thorough note.
Boy, that's
but it also really made me think about what I was doing. Like, really assessing the patient, just continually taking these snapshots.
Have you ever been deposed? Have you ever been through that?
Just once.
How was it? Was it intimidating?
No, not really, because my note was really great. I think, I think the weird thing that I had to convey was that they were saying this was, I want to say, good Lord, before troponin, right? Like before we were really using troponin to rule in or rule out MIs.
Yeah.
And so this person had come to the ER with some chest pain and everything looked normal, right? Except for the troponin. But it was so early in the use of that the doc just didn't know to consider it.
Yeah.
And the patient, ended up going to another hospital and getting 6 stents or something later in the evening. But, this is, 1999, 2000, this happened, right? And I don't think that I was deposed until 2005.
Holy cow.
So, not only did I have to, be able to walk through, like I was the triage nurse, and walk through like, this is what they look like. And they're like, well, what about this? I'm like, oh, we didn't even use that then. Because I'm looking at like, why would you send somebody home with a trope of, a bumped trope? It was like, I don't know, like 0.5 or something.
Wow.
And good Lord, why would you send somebody home with that? And then I realized like nobody was using it then. It wasn't standard of care.
Huh. And were you able to convey that to the lawyer?
Yes. Yeah. I said, based on everything but the troponin, it was completely reasonable to discharge this patient for outpatient follow-up. EKG was normal. Other labs were normal.
Huh.
Patient looked okay. Yeah.
That's crazy. So I've not yet, knock on wood, been deposed based on my care, but I was once deposed I worked as a security guard, and I got deposed, and it was the most intimidating, terrible thing I've ever been through. And I ended up looking at the transcripts, and I sounded like a complete idiot. I was like,
the thing. Well, a lot of it is sort of don't answer questions you haven't been asked. I think that everybody wants to kind of contextualize what their thought process is, but if there's anything I've learned in studying triage is that people will do almost anything to justify the bad decision that they made.
Right. For sure.
With regard to triage and stuff. So, that I think was one of the best pieces of advice I ever got. And the other one was, the problem is bigger than this, which was what my dissertation chair told me. And so I went from going into my first year of graduate school at BC with like this nice little, comparative study about men and women with chest pain and whatever. And she's like, yeah, there's a theory here. So we're going to get you to the point where you can see it too. I'm like, oh, okay, sure.
That's funny.
Yeah.
It's, I think going back to triage and going back to notes, I look at triage notes all the time in my current role, and some of them are just terrible. They're
terrible. Well, it's those checkoff boxes.
Yeah. I mean,
right? Like you need a narrative.
And I tried explaining to folks at my one of my last jobs where I was a director, and their triage note was just subjective. There was nothing no objective information there at all. And no evidence of any kind of intervention, assessment, anything. It was essentially they were writing the chief. They would write the chief complaint. The clerk would write the chief complaint, and then the nurse would essentially write the chief complaint with maybe another paragraph, and that was it.
Wow.
And that was it. And it was, I was like, okay, patient states that he's had chest pain and shortness of breath for 3 days. That's it. Right.
Without and this is his color, and this is his mentation, and this is his pulses, and all that stuff. Sure. I really think that whole idea of think like a lawyer, it really drives advice. That. Right? Like, what happens when your patient dies in the waiting room?
Absolutely.
How does your note reflect the fact that patient was, at least to all, normal criteria, that patient was okay to be waiting in the waiting room?
Yep. There was a hospital here locally that had a patient die in the waiting room not that long ago, and it's like I would have loved to have seen that triage note. And
oh my God,
can you imagine? I mean, it just the thought of something bad happening like that is just terrible. But then you realize that 5 years from now, when you pull up that note and you're going, I don't even know what this means. Right. I used to always tell students, paint a picture of what you see.
Right. Take a picture. Absolutely. Give me a snapshot.
Yeah. And so I like that. Think like a lawyer, or chart like a lawyer. I really like that.
Because if you're going to send somebody back to the waiting room, assuming, right, if your default is everybody's emergent until proven otherwise, you need to chart why they're not emergent. Why are you not taking that patient directly to the back?
Absolutely.
Well, this is why, because their color's good and their vital signs are fine and they have no risk factors and they're warm and dry and they're mentating well,
Yeah. Now then, do your triage notes just get super long and super verbose? Or do you...
I don't think so. I think there's a mental checklist, right? And you don't really even need to do so much a review of systems, but you do need to, what are the signs that a patient's going to crap out on you, right? They get confused, they get pale, they get clammy, they get ashen, they get gray, they are tachycardic, they have difficulty breathing, right? If you just chart that none of those things are present, then you're good, you know?
I almost felt like at times with my triage, I had I almost felt like it was like Mad Libs. Or remember do you remember Mad Libs?
Triage Mad Libs. Oh my God.
Do you remember that?
We should do that. We could retire on that idea.
This is a brilliant presentation idea. Triage Mad Libs. The patient is A&O times blank. Skin is blank, blank, and blank. And
right.
And you kind of fill that in. And I remember teaching EMS students. I spent a lot of time teaching EMS students, and I would teach them to write narratives, and it was almost like Mad Libs. I was like, guys, you can write 90% of the stuff, and then just kind of fill in the blanks.
And then just fill in the blanks. Absolutely, that's how ICU charting is.
Yeah, and you would cover everything.
But here's the thing: this is how doctors' notes are now written. Because they have that Dragon voice software.
Yeah.
So the note is the like history of present illness and the emergency physician note. They're all essentially pre-populated, and the physician, like where the blank space is, says a word, like moves the cursor, clicks on it, and says a word. So it's really exactly like that. It's Mad Libs.
I had no idea, because I always thought, I've seen some physicians dictate, but I thought they were just like fully just narrative, like speak it all out. I didn't know that there was
Depends
like
on the software. Depends on the software, but there's definitely a program in use at one of the hospitals I work at.
It's like
because it saves them so much time. And
of course it does.
They're really, I think those notes are structured for billing purposes.
Of course they are.
Right? So as long as they fill in the blanks, right, all the areas are covered and they can bill appropriately, but they are also useful to paint that picture.
Do you think nursing will ever go to dictation for charting?
I don't know. I really... Okay, so my thoughts on computer charting are, probably peppered with obscenity.
Yes.
But
yes.
Because it is a checklist, it makes nursing a checklist rather than an assessment.
Yeah.
And I think the idea of the narrative, the way it used to be, required that people could really think through and paint that picture in a way that does not seem possible with the current computer charting. So the poor people at one of my hospitals, where they use something called Meditech, which I understand is like antediluvian.
The worst.
But there's plenty of free text space.
Yeah, it's all. I think that's all it is.
I just click on additional documentation and I write my note. First contact with patient, this is what they look like, this is the plan, boom. I don't have to, because the turnover in my ER is really fast, I don't have to write another note until I do the discharge assessment. So, it's worth it to me to take that extra 3 minutes to really write a note, especially since the patients at this hospital are generally in and out. If they're not sick, they're in and out in less than an hour.
Yeah.
So if you've got 5 patients, you can turn around to go back and chart, and the patient's like gone. Somebody's helpfully discharged them for you.
Yeah. Like I was a nurse at the tail end of handwritten notes. So as I was just kind of coming on, we were starting to go towards computer charting. I still remember handwriting notes and having the little mailbox looking things in the rooms where you just throw the chart back up there and walk out and go chart on your next person. And and boy, then the computer changed everything.
Yeah, not always for the better, but yeah.
No, not always for the better at all. I mean, there's pros and cons, right? I mean, so at least you don't have to interpret Dr. So-and-so's handwriting anymore.
Sure.
Sure, that's a good thing, because that was always difficult. It's like learning a foreign language. But the bad thing is so many nurses spend so much of their time sitting at the keyboard instead of actually taking care of the patients, making a connection with the patient.
Right.
And
I think what I try to do really, really a lot, and I can do this, I think, because I have 20 years experience, is I can hold all the information I'm going to need to get in my head. Like I can go in, have the conversation with the patient, get the information, connect with them, and then write it down.
yeah.
And I think the newer nurses may not have the experience to be able to do that. So.
No, I think you're right. I think it's a little bit more difficult. One of the things, my wife was recently in an ER, and I was impressed because the young lady who was looking after her came in and she brought her WOW in, and she was kind of asking her questions and kind of clicking through her check boxes as they do, but then sat down and like really was like talking to my wife and like having a conversation and listening and gets up and kind of listens to her lungs and gets up and kind of feels on her belly and stuff. And I'm sitting there going, this is good to see. Instead of just,
thank you for putting your hands on the people.
Right. And it's sad that we think that way, but how many people don't?
Yeah. Well, that's a problem because you're missing a lot of assessment data.
Oh, it's huge. So much data they're missing by not putting their freaking hands on the patient.
Right.
Like, I remember I worked with a doc named Dr. Tamberg, and Dr. Tamberg would, he would go in and sit down and he'd talk to the patients. His opening thing was always, so what can I do for you? What do you need? And he'd kind of go through, and then he'd get up and he'd listen to their lungs, listen to their heart, kind of feel their belly and that kind of stuff. And whether it was appropriate or not, whether like he needed to or not, and he was just like, it's just what he did. And I remember one time asking him, because there was someone there for something silly, and he, listens to her lungs, feels her belly, listens to her, listens to her stomach and talks to her, and he's doing this little kind of mini assessment. And I go, so why did you do all that if, she's here for a stub toe? I don't know what she was there for. And he's like, because I'm a doctor, Kevin. That's what they expect me to do. And I was like, I guess that's kind of true, but also look at the information you're going to get from that. Like how many things have been found accidentally.
Right. Well, the other thing is that I think people have really terrible experiences in the emergency department when they feel like they're not seen, or like nobody even examined me, or nobody even paid attention to me. Right. So you have a doctor who goes in there and does a reasonably thorough exam, like, oh, he's concerned, like there could be other things that he's looking for, and
absolutely,
and okay, I feel cared for.
Yeah, and that's one of the things I've always done as a nurse. I go in and try to do a real good assessment, sit down, try to talk to the patient, and try to one, to make sure I'm not missing anything.
Right.
So interesting. Tell me about a mistake that you made in your nursing career that you look back and you're like going, oh, what was I thinking? Something that you can share with the audience. A time that you looked back and you said, oh, I didn't do that well. And what would you do differently?
Yeah. Well, I think, let me see. God, it's been a long time. I must have made some really terrific mistakes. Oh, I know. Sure. Then, fortunately, none that resulted in patient harm, which is really nice because
Good.
Sure, all of them could have. But I remember being in an ER down in New York, and it was just a really wild night, and we were all trying to help each other out. We had all these crazy names for beds, like besides the numbers of the bays, there was also like, by the pole, under the clock, outside, 16, 1, 2, and 3. I mean, we had beds all over the place. And a colleague of mine said, hey, can you medicate the woman under the pole? Now, mind you, where, she needs like Keflex or something like that. Yeah. Can you give a Keflex to the woman under the pole, woman under the clock? And I was like, okay, sure. So there's 2 beds under there. And so I go and I, am about to give the Keflex. The woman's like, well, what is that? I'm like, oh, it's Keflex. And she's like, I'm allergic to that.
Oh.
And so I was like, then why would they be giving you that? Well, I was supposed to be giving it to the other woman who was under the clock. So, couple of things, like one, don't just sort of grab things and throw them at people. That's like number one. But the second was the very important process of identifying people. Now, this is like back in the day when there was no Pixis, there's no CPOE, like everything's handwritten, and there's verbal orders being yelled
everywhere,
across everywhere, but without any identifiers, like without any names. So I was like, okay. So from then on, I've been like almost ridiculously anal about like, please give me the name of the patient. I mean, now of course with computers, it's different.
Yeah.
And scanning people and stuff, which although annoying, is really helpful to prevent those kind of errors.
Yeah, for sure.
But really, I was like, from then on, even though like the department remained crazy and we still had verbal orders all over the place, I was like, okay, I know we're busy, but can you please tell me the patient's name? Like, this may require that you learn the patient's name, because half the time, like, we didn't even know the name of the patient. So that became really important to me to always, make sure I had the right person, check allergies, because half the time you're the third person on the match, and then they don't even find out about the allergy, so you're about to give it to them and stuff.
Right.
So I think that might have been like the biggest mistake. I'm very timid and anal. So
Understand.
I'm always terrified of making mistakes, so I don't tend to make a lot of them.
There you go. If you're careful, that's a good thing. So I'm going to ask you some kind of leadership questions.
Okay.
What do you think is the most important value? What values do you value most in a leader? What are personality traits or what characteristics?
I think the things that are really important for good leadership, like benevolent leadership, is a sense of community and a sense of justice and an understanding that the issues that pertain to their given emergency department are both, very particular to their environment, but also reflective of bigger community problems. Does that make sense?
It does.
So a good leader is someone who is in service to their community. And that community, if you're the leader in an emergency department, it's, you're leading your staff, but you're also providing leadership for your community, because the emergency department is the canary in the coal mine. So it's incumbent on emergency department leadership to really call out trends that are problematic. We have a lot of flu here. We have a measles outbreak. Like, what are we going to do about that? To really provide clinical leadership to their department, but also provide kind of the ethical piece of healthcare to their community. That's what I think.
How do you think ethics plays into the everyday emergency nurse's role? You've mentioned ethics a couple times, and I know that's something that's that's near and dear to your heart. How does that? But I don't think it's something that most ER nurses think about daily. They don't think I have an ethical challenge here. I have this ethical dilemma you mentioned earlier. How do you think it plays into the everyday nurse's role, like daily?
Yeah. Well, I used to tell my students and my orientees and basically anyone who will listen that every nursing decision is an ethical decision. Every single one. Are you making your decisions for the good of the patient, or are you serving some other master, right? So the ethical conduct of nursing means that you you function in an arena of beneficence, so doing no harm. Doing good, non-maleficence, doing no harm. Justice, meaning that everyone who comes into your department gets your best effort, right? And I think that's an ethical piece that a lot of people kind of miss a little bit, right? There's this sort of weird Calvinist understanding in the United States that some people are deserving of health care and some people are not. And that doesn't just reflect the idea of everyone should have health insurance, right? But that everyone deserves health care.
Yeah.
And I think when we dehumanize other people, people come to us at their very worst moments, whether it's a medical crisis or a psychiatric crisis or a substance abuse crisis, right? People are coming to us at their time of need. And if we are putting forward some kind of judgment as to who deserves my best effort and who does not, then we are not conducting ourselves ethically. We take care of everybody. And, I've got 20 some odd years experience and a PhD. And you know what? Anybody who comes into my department gets the full weight of that knowledge and experience because they deserve it by virtue of their being a human being. And especially in emergency care, I think we tend to really do a lot more eye rolling than is good for us,
Oh, you're absolutely right.
So in the sense that, okay, to like bring this down to a really operational level, right? So, Larry the drunk comes into my department. Larry the drunk has been here 3 days this week and 3 days the week before and 5 days the week before that. And do I assess Larry the drunk with the full weight of my experience and expertise? Do I actually look at him and see through, sort of the grime from under the bridge and see the person there and see their physical condition, their mental condition? Do I make any attempts to make sure that they're physically okay? Because these, of course, are the sickest people in our departments. They're nutritionally
absolutely.
bereft, they're cold, they're hungry, they're septic, they're all kinds of things, right? But if we can't see past that label, then we are not conducting ourselves ethically. Does that make more sense?
That makes a ton of sense. Now, how do you, so, you're like me and sometimes come in and, go into the emergency department, sweep in, do a princess shift, and then say, peace out, guys, I'm out.
Right.
I'm sure you work with nurses that are every bit that eye roll nurse that, oh God, here comes Bob again. Jeez Louise.
Sure.
I took care of him yesterday. How do you change that culture? Can you change that culture?
Well, here's the thing. I have also rolled my eyes, at Bob who comes in, right?
Absolutely.
But what I've learned to do is to say, oh, I'm rolling my eyes. That means I have to really have like some laser focus because I am at risk of missing something because of my own blinders, my own bias.
How big a problem is our own bias?
Huge. It's everything. It's why we under triage people all the time.
All the time.
All the time. We under triage people like at ridiculous rates. The triage accuracy rates, if you look at the literature, there's not a lot on it, mind you, but it's about 60% accurate.
That's it?
That's it. And do you know why? It's not because people don't know. It's because people ignore what's in front of them. Like I've done a couple of different studies on triage. And what I can tell you is that people do not assign acuity based on physical presentation. They base it on how many people are coming in, like what the volume is, and who's in the back, who the provider is. Right? So if my department is totally crowded and I have somebody come in with like they're tachycardic, they kind of meet SIRS criteria, but they look okay. If I make that person a 2, which I should because they meet SIRS criteria, my charge nurse is going to give me so much grief because now I have to find a bed.
Got to find a bed for him.
Find a bed for that patient, right? Yep. I have a patient who comes in, and I ask the universal screening question in this way. You're not feeling suicidal, are you? Making it really clear to that patient that the answer to that question is no.
No.
And is no, because then I don't have to bring them right back.
That's true.
Right? So I am not triaging based on what is in front of me. I am triaging based on what's in the waiting room and what's in the back. This provider doesn't want to take care of kids. So even though this kid is a very benign, thing up the nose, I have to make this kid a 3 to send them to the main department, because the main department doesn't take 4s and 5s.
Yep.
Right? So that we are manipulating the system to address flow problems in the department.
It's a good point. I remember having conversations with people saying, not every 4 and 5 has to go to urgent care, and not every 3 has to go to the main emergency department.
Right. Right. I mean, but the issue is really, we under triage women. We do not take their pain seriously. We do not, appropriately triage minorities in certain places. People just don't see their own bias. But if you look at it out in the data, you're like, holy crap! Why are we not seeing this? Why are we sending 22-year-old Hispanic guy with chest pain back out to the waiting room rather than asking him if he has Marfans or if he's got any history, or you know what I'm saying?
So you mentioned, one of the things you mentioned was being aware of your bias and being like, okay, hyper focus, because I think this guy's full of shit. Let me make
really sure he's full of shit.
is that the best advice for a new nurse getting ready to go to triage? Is that the best advice for him, is to be aware of your kryptonite, as it were, or be aware of your...
Absolutely. Really pay attention to how you're feeling about these patients.
Yeah.
And that's also probably a reason why you shouldn't do more than 4 hours at a stretch in triage, because after a while, everybody looks the same.
It's true.
You can't differentiate between, fever, cough, sniffles, and, fulminating sepsis.
Yeah.
Because it all looks the same.
I remember many 12-hour shifts where it was just all a blur. I remembered maybe 2 or 3 of the people I triaged, and I triaged probably 50.
Right, exactly. And when people say to me I want to stay in triage, I'm in a groove. No, you should not be in a groove.
Yeah.
you should be ready to vomit at all times when you're in triage.
That's one of the things that we tried to do it in an ER I worked at, is really tried to break up triage. That nobody needs to spend 12 hours in triage. But
no, it's
hard.
Switch back and forth.
It's hard to get nurses to do that. So the 2 places I always thought was hard to do a full 12-hour shift was in the trauma and recess room and in triage. Those are the 2 places where it's those are 2 places that if we're going to break anything up, what better place to do it?
Sure, because you're not taking care of patients for 12 hours in a recess bay. You're doing stuff and you're sending them out.
Exactly. Exactly. No. What type of leader would the people that you work with say that you are?
A very direct one.
Is that a good thing or
you
a bad
never
thing?
have to worry about wondering what I think about things.
I appreciate that.
I know, I do too. I think there's a way to be direct without being mean. And I'm from New York, and I'm an ER nurse, right? So what else do you expect?
Yeah.
But I think there's a way of bringing people's attention to things that does not involve sort of that weird passive aggressive. Do you think you could maybe possibly? And be like, look, this is what needs to get done. This is how I need you to do it. If you have any problems, come and find me, right? So I've been managing, the department, the research department at ENA for 7 years now. And, no issues. We have had no turnover in our department.
That's awesome.
In 7 years. So, yeah, it's really awesome. So, I think I enjoy leading people who are on board, like you have to have a shared vision. You have to understand like where you are in the machine, and where you can kind of step out of that and where you kind of have to stay in line, and, negotiating that with people who are equally direct, I think, is good. Having been an ER assistant manager, I think you really need, it goes back to the first thing that we talked about the other day, right? Like you got to know your shit.
Yeah.
You have to be able to do the job you're asking other people to do.
Absolutely.
Right. And I think this is where people who come out of school and go right into management after a year have a really tough time of it, because everybody's looking at them like, you can't start an idea. Like, you can't do my job.
Yeah.
Why are you telling me to do things that I know are impossible, but you don't actually know are impossible because you don't do this job. You have never done this job.
It makes it tough to lead if you're not there, if you're not competent.
Right. If you can't, like, if you're a manager in an ER and you can't if you can't walk out of your office, put on scrubs, and get to work, then you have no business being there, as far as I'm concerned.
Yeah. I think at the manager level, that's absolutely true. I think at the director level, there's maybe maybe not quite as much. I mean, you should be functional. Do you need to be
right?
The expert?
You should be able to take the desk, if nothing else.
Absolutely. Absolutely.
Like if things are going crazy, you should be able to be useful.
Yeah.
Even if being useful means ordering pizza. So.
Yeah. Absolutely. What part of being a leader do you think is the most difficult? What part of being a leader do you think is the best?
I think it's difficult when you have to try to. So there's two different pieces, right? So as sort of a thought leader or a process leader, like that's really fun because you pull together all this data and all this information, all this experience, and you kind of lay the path out, right? Like, this is where we're going, guys, because this is why. That's kind of the fun part. I think the difficult part is when you're dealing with folks that either can't or won't evaluate the process on its merits, right? So everybody's got an agenda, right? We all have agendas. The question is, can your agenda serve the interests of your community? Or are you kind of on a little ego joyride?
Yeah.
And it's always good, I think, to have people, whether they're your work colleagues or your, friends, partners, voices of reason, who say to you like, okay, back off there, Napoleon. You're kind of charging ahead without a lot of lot of support there, right?
Yeah.
So, yeah, I think it's challenging to balance like your own vision of what needs to happen and like the reality of what needs to happen.
Yeah.
Sometimes they align, sometimes they don't, but
it's nice when they align, but sometimes you're like, boy, this would be really cool if we could do this. And you're like, we can't even effectively triage and take care of patients. You're like,
right, exactly.
Slow down. Let's walk before we can run.
Right.
Yeah, I understand that. My first director role, I came in like, I'm going to change all this. I'm going to do all these really cool things. And I'm sitting there going, and then, eventually I was just like, I just want them to be able to effectively and safely triage. That's all I want.
Right. Right.
Like, is that too much to ask?
But that changes everything when you actually are doing that right.
Yeah, absolutely. It makes a big difference. It's funny. So, what's the most difficult decision you've had to make as a leader?
I think when I was in charge of education in my ED about a dozen years ago, getting real, like telling people that they didn't belong in the ED, at least at the moment, right? Like developing essentially the criteria by which I would exit people from the emergency department, and that's never easy. Like I think as nurses, we like to take care of people, right? Like that's what we do, and you see that reflected not just in our work, but in our relationships. And it's very difficult, I think, to let people fail, or tell them that like, hey, this is not for you.
Yeah.
So that was, at the time, seemed incredibly necessary to be able to do, though, because people were sort of not being triaged out of their orientations appropriately, right? It was sort of like all comers, and then that's not really serving patients, right? So it may make our staffing numbers better, but these are not people who belong here.
Yeah.
So kind of really balancing those risks, one against the other, like, oh, we're going to be short-staffed again, but we're not going to have people who are going to kill people, so that's good.
That's incredibly important. I mean, I think that there's so many people that I've, in my career, I've just wanted to say, you need to go do something else.
Right. Like, please go to art school. Like, that would be great. You can't kill anyone with bad art.
I remember it as an instructor, as an EMS instructor, watching people and watching them do these scenarios and watching them learn and going, boy, let me take you over and introduce you to the guys over in welding, because this isn't for you. Like, this isn't for you.
We're going to take a walk over to cosmetology.
That's right. We're going to teach you how to paint nails or something. I don't know. 'Cause this isn't working out.
Right.
This isn't working out. We had a great student. He was so smart, but he was like almost Aspergery, if you know what I mean. And like, I was like, you can't take care of patients. This isn't in the cards for you, dude. And he wanted nothing more than to be, he wanted to be a doctor. And he's starting with EMS, and I'm like going, you need to go into like IT or something. You're not this.
Right. Well, we ran into this all the time with I taught in a second bachelor's program for years.
Oh my God, I bet.
And, and they're all like, well, I have a 4.0 average. Hey, that's great, but you still can't recognize that a blood sugar of 29 is bad. So you don't get to be a nurse.
I bet I bet that was tough, because there's people that like were doing something else and maybe found success, maybe didn't, but then they were like, right, well, I'm going to go do this now. And you're like, no.
Just because you were a good Spanish major does not mean that you're going to be a good nurse.
No, not even close.
Nope.
So when you interview people, how do you, like, what do you think? How do you think you tell that, like, in an interview? If you're a new leader and you're interviewing people for your department, how do you know who's not a good fit? Like, do you think there's a way?
Yeah, I do, actually. I wrote an article about this.
Of course you did.
Awesome. Of course I did. Sure. Hey, just Google it, man.
I had to read your articles before I ask you these questions.
I know. It's so funny. Well, I just sent some stuff off to this woman who called me the other day, and she was like, retention. We're just, we can't keep anybody. I'm like, okay, you got to hire the right people. Yeah. So really you want, I think back in the day when I was doing this, I haven't interviewed anybody in a while for a ER job, but I think what I really focused on was, like, any idiot can learn how to do tasks, like skills. Like, totally. I can teach anybody to start an IV.
Absolutely.
The issue is more, can you recognize acuity? Like, even if all you do is go get a grown-up, right? I used to tell my students, go get a grown-up. And
that's funny.
And I think a real acknowledgement of their complete ignorance, right? Like, I want to hire somebody, I say, why do you want to work in an ER? It looks really cool. great. What do you know about ER? Nothing. Like, but I'm here to learn. I will learn anything you can teach me, rather than, well, I did this for a while, and so I'm sure I'd be good at this. I'm like, so are you a good waitress? Because if you're not a good waitress, you're going to die here.
Right.
Have you touched people? Have you seen sick people? Do you, more just in a willingness to learn, I think, was the key thing, right? Because you can't teach that.
Nope.
The rest of it you can teach. And also if they show up late, unless they've got a fantastically interesting story.
If you're going to be late for an interview,
your first impression, I can't even imagine what you'll do.
If you're going to be late for an interview, you better have a really good story.
I'm waiting. Tell me the good story.
You're like, this is going to be good.
I know. Let me get a cup of coffee. You tell me why you're late. And I'll decide whether this interview continues based on your answer.
That's right. Here's the first question. Let's see if you get past this, Skippy. So.
Right, exactly.
That's
Come on,
funny.
Junior, have a seat.
That's funny. It's hard to hire people. It's hard to hire people and find the right people that, like, one, you want to work with, and two, like, are competent and safe and will do good things.
Right. Yeah. I mean, this is not something that everybody can do. I mean, when I went to nursing school, back in the days of the dinosaurs, they would say, like, hey, look to your right, look to your left. Two of you won't be here at graduation. It was ruthless. And it wasn't as, like passing was 77, not 72.
Right.
I mean, which really still doesn't seem very,
right.
Very stringent, but there it is. I think that especially in the clinical piece, like, they were on you like a hawk. They were
bad.
If you couldn't do the clinical stuff, it didn't matter what your grades were. In the theoretical stuff, like, you were not safe to be around patients. And they were just really all over that. And I find that no longer exists in a sort of a consumer environment where students are consumers and they're paying, and therefore it's like somehow the instructor's fault if they can't be safe, you know?
I remember when I was going to nursing school, there was a woman who was in nursing school with me, and she looked every bit. I'll just say she looked like a junkie. She looked like she was probably rode hard, put away wet. She looked like she'd lived a rough life, and certainly she never seemed impaired or anything like that. But she just had kind of that look, and that sounds super judgy of me to say, but I think that a lot of people will know exactly what I'm talking about. And I remember the nursing instructors, like, they weren't even going to give her a chance. They were like, there's no way. Like, she was done before she started. And they watched her like a hawk, and they were, and they looked for, I'm not going to say they looked for things to get her out on, but they weren't not looking. They were keeping a close eye on her. And whenever anyone's keeping a close eye on you, of course you're going to do something. But, and I remember having really mixed feelings about it. And that I was thinking, God, this is too bad. She wants to be a nurse. She wants to take care of people. That's good. And they're just like, no. I really had mixed feelings about it. And I still do, just saying it now. I'm like going, God, what do you,
right.
Who knows?
The other piece of it is that, and I saw this a lot in the second bachelor students, like in the adult students, you can't work out your trauma on your patient.
No, that's
right.
For sure.
Like, you can't, and that, because again, that is unethical.
Yeah.
And so I saw a lot of that. I'm like, whoa, this is not the place to work this out, folks.
Yeah.
Go get some therapy and then come on back.
Come on back down the road. We hired a traveler once, and we did this interview over the phone, which is always super difficult to do. And the day she interviewed well over the phone, and the day she showed up, like, I would have sworn I was like, how did you pass a drug screen? Like I just, and again, me being super judgy, but I was like going, there is no way you passed a drug screen. And, and, whether she did or not, I'm assuming she did. She had to have. But certainly you wouldn't guess that to look at her. And it just, like instantly the staff were like, ugh, oh. And they never gave that woman a chance.
Yeah.
And she may have been a fine nurse, but she never really got a chance. So I don't know. It's weird. It's weird. I get it, but it's weird. Like I feel weird just saying it. So
yeah. And again, that's where kind of like, let's assess a little farther, right? Like, why do I have such a visceral reaction to this person?
Yeah, and you do. I guess it's that whole triage conversation all over again. Like,
right.
Yeah. If you're starting with an eye roll, pay close attention.
Pay attention to what you're missing.
Pay attention to what you're missing. As a leader, what has your attention right now?
I think I am fielding probably a couple of calls a week from people who are frantic over their staffing. These hospital systems are spending huge amounts of money on consultants who come in and, of course, tell them that they should be cutting their staff. And I think that there is a willful denial of the intellectual work that nurses do. And this idea that like literally we're waitresses, right? That we're running around checking things off a list, and that's what we do. And so it doesn't really matter your experience or your education or your training. Just put a body in there, and fewer bodies than are needed. What I'm finding is that all the work that we've done over the last, I want to say 6 years, right, with the IENR Advisory Council, the work we've done on fatigue and moral distress and bullying and, critical access hospitals and just tons and tons of stuff. It all comes down to staffing, right? You can't, places that are understaffed have really tired nurses. And really tired nurses not only make mistakes, but they're mean. And they're mean to each other, and they're mean to the patients. And then, they're even more tired because it's tiring to be mean. Yeah. And, there's this sense that we can't possibly give the care that we want to give. And now you've got this moral distress. You have people who are tired and mean who are not paying attention to escalating patients or giving their colleagues information on patients who might escalate. And so we have more workplace violence in those situations, right? Like all of this stuff can be fixed with appropriate staffing. And the one thing that hospitals seem reluctant to do is to provide adequate staff.
Address that problem.
Right. I mean, this is like life and death decisions that people are making. And if you exhaust them and hit them enough times, then they're all going to leave, which leaves you with a whole bunch of brand new nurses who don't know anything, right? And so there's like, oh, how could we possibly ever fix this problem? How about you bump up your staffing? Oh, no, we couldn't possibly do that.
You're like, no, that's not the answer.
Right. It's infuriating. This whole idea of like, well, you wouldn't be so tired if you just did some self-care, I'd be like, fuck you. Like, what does that mean? Self-care in this case means advocating for better staffing.
Yeah, you're right. I remember many a short shifts where you're just like, you leave and you're just mentally whooped.
Yeah, absolutely. And you're replaying everything in your head and you're hoping to God you didn't make a mistake.
Yep. Yeah.
And I think that's the most frustrating thing because the vast majority of issues can be tied back to that.
Now, I haven't looked at ENA's staffing recommendations. what's kind of the recommendation? What's the recommended ratio? Is it a ratio?
We don't actually have a ratio.
How do they do it?
Yeah. Here's the problem, right? So what we do in our staffing guidelines is we ask people to look at their volume and their length of stay.
Okay.
All right. And then, we kind of calculate how many FTEs you need.
Yeah, it's just kind of general. Uh-huh.
It's kind of general because each department's going to be different in how they deploy that, right?
Of course.
So you may need way more staff on Friday and Saturday nights than you do on Tuesday mornings, right? Like it's not, if Monday morning is I couldn't get to the pediatrician day and it's all colds and coughs, right? You're going to deploy your resources differently than, trauma night.
Yep.
So, so the problem with ratios, I spoke a little bit about this at the annual conference. The problem with ratios is that absolute ratios have not been tied to patient outcomes.
Yeah.
What's been tied to patient outcomes is education and skill mix.
Okay.
Right? Now, to me, this is also a chicken and egg problem, right? Because a hospital that can hire only baccalaureate-prepared nurses and provide them with the appropriate education has a different culture than a hospital that will hire anyone with a pulse.
Yeah.
Right? So it's not necessarily the absolute numbers, although there is certainly a component of that, right? Like you can't take care of 10 people at once.
No, yeah.
You just can't, right? And so, but a lot of emergency departments at night, that's functionally what people are doing.
Yeah.
And that's not safe. And we know it's not safe. So, I think that what we say is like, here, boom, here are your FTEs. What I end up fielding a lot of phone calls about, and this is where kind of the new staffing guidelines module is going to address it. People are like, I can't show this number to my administration.
Yeah.
They'll just say no, right? I'm like, well, how come? Well, it's way too high. How many nurses do you have? This many. Are you working short? Oh my God, all the time. Okay, so then the number is not wrong.
Yeah.
The question now is like, what is the context? And this is where I see research data as being really important in building the case for appropriate staffing. There's certainly a financial case to be made for appropriate staffing.
Yeah.
If you're replacing nurses every 6 months because they're all leaving, that's costing you way more than just hiring the ones enough people.
How do they not see that? I struggle seeing that.
I don't know.
In my current role, I struggle seeing that where I'm like, hire some nurses. Holy cow.
Right. Or even like to hire an educator.
Right.
To support them, right? Like, so when we were doing the new grad programs and stuff, I'm like, you have to hire an educator.
Yeah.
Oh, well, that's too expensive. Okay, 4 of your brand new grads after 6 months walked out the door. That's $240,000 you just lost. You're telling me $90,000 for an educator is too much?
Right.
I mean, come on.
Yeah.
Do the math, man.
Yeah, do the math.
Do the math.
I look at these hospitals and I see hospitals now that they got everybody working. Everybody working overtime. Everybody's doing at least an extra day. Many are doing more than that, and you're like, I want to tell the leaders.
Burn out.
I want to tell the leaders, you're burning out your staff. You're burning them out.
You're burning them out, but it's all short term. It's all like, we just got to get to the next shift. I don't care what happens. We're staffed for this shift. We're just gonna
see what happens next shift. 12 hours at a time. 12 hours at a time.
Right. You can't do it. You cannot do that. And, people are like, well, there are all these great bonuses. Okay, great.
Great.
How soon till you get sick? How soon till you just don't want to do this anymore?
You can have a heart attack with a lot of money in your bank instead of just a little bit.
Right. There were people that I knew in New York who were working 2 full-time jobs.
Oh, I know a couple people doing that now.
But, everybody marks their lives in 4-hour shifts of overtime, right?
Yeah, it's true.
Like, oh, okay, I want to get that. All right, that's 3 shifts, Vacation in Disney, that's 10 shifts. I can do that,
Nurse math. Yeah, absolutely.
Nurse math, absolutely.
So you're absolutely right. And It's crazy. We do it to ourselves, and then we're like, God, why am I so burnt out?
Right.
Like,
I should really take a day off.
I should take a day off. You're like, yeah, you should. So
Yeah. I mean, let me tell you, I have like 400 hours of sick time saved up. I have been at this job for 7 years, and I think I've called in sick, like, I don't know, I could count it on two hands in 7 years.
That's funny. You're like, sick time. Yeah. Who needs that? It's crazy.
Like, damn, I need a sabbatical.
That's right. That's right. You need a sabbatical. You mentioned that there were some parallels between one of your hobbies and leadership and nursing. What was that hobby, and what's the parallel?
Let me think about this again. It was probably thinking about fencing.
That's exactly
right. So so I'm a competitive fencer, and I think the thing that is so amusing to my friends about that is that it highlights very clearly every single personality flaw that I have. And I think that when we talk about like the whole idea of leadership and figuring out kind of how you move people along, right? It's like it has to be very process oriented.
Yeah.
Right. So we've got to get people to understand that like there's an arc here, right? There's a process. You start here, you put in the time and effort, and the result comes out here most of the time, right? And I think that especially when you can give people the longer view, it keeps them from getting discouraged. When you're talking about training new nurses or working with, staff in terms of, improving things.
Uh-huh.
That's, I think, what I was thinking of.
Okay. Do you enjoy the fencing? How long have you been doing fencing?
Like 8 years. 8 years now.
What's the coolest part of it?
Hitting people with swords. Oh my God.
Oh, duh.
Kidding me? Duh. No, I started it in the middle of my PhD program, and this flyer comes home from my kid's kindergarten. I was like, oh my God, I've always wanted to do this. This is the most coolest, badass thing ever, right? So the club is around the block from my house, and I go, and I'm like hooked. I'm like, this is amazing, because there's so much thinking that goes into it.
Yeah.
And, like, it's all mind tricks, right? Like, I'm going to set this whole action up so that you think I'm doing one thing, and I'm going to do something totally different, and it's going to be great because I'm going to hit you. Right? It's so great.
That's awesome.
So, yeah, but it's really allowed me to focus a lot more on process and a lot less on results, although, finally I'm kind of getting results. So, it's also like, who's your competitive group, right? So the group in which I am most competitive is vet 50 women, right? So the vet category is everybody over 40, so it's like a master's category.
Okay.
But the fencing association kind of divides into decades of competition, right? So. So in this category, I'm ranked 10th in the country. So
Shut
that's
up.
like, it's super fun.
That's awesome.
But it's like a lot of work. It's not something that you just like, I think, are good at in your 40s, if you've never done it before. So it required a lot of patience, which I'm bad at. So, I think it's just been really great. It's like therapeutic. It's very physical, which is terrific because it blows off a lot of that anxiety that you get, worrying about killing people.
Yeah. Okay. How many nurses have boiled it down to that specific? I worry about killing people. Like,
Too few.
It's mind blowing that, like, that's our goal in a 12-hour shift. Don't kill anybody.
it's a very simple goal. I actually have, this is fabulous. I have a T-shirt from one of my last cohorts of undergrads before I left teaching, and it's a T-shirt from their bar crawl, like their senior bar crawl, and it says on the back of it, "Keep them alive till 7:05," which is what I used to say to them all the time. And underneath is WWLWD. Like, what would Lisa Wolf do?
That's awesome.
It was hilarious.
That's hilarious.
It is hilarious. So I think that, my focus for my students has always been, like, please don't kill anybody.
Yeah. Yeah.
Like, that's the goal.
It's a lot of paperwork.
That is exactly my point. There is way too much paperwork when you kill people.
Yeah, there's
but that's the bottom line. Like Airway before self-actualization.
This is the funniest thing I've ever heard in my life. The funniest thing I've ever heard in my life. It's the funniest thing I've ever heard in my life.
Well, especially these second batch students, right?
Yeah, you're like,
well, I've come up with this really important plan, for their psychiatric well-being. How about the Airway? Have we addressed that?
Have we kept them alive?
Have we kept them alive so they can be self-actualized?
That's hilarious. That's the funniest thing I've ever heard. That's got to go on a T-shirt somewhere.
Right? Airway before self-actualization.
That's right.
I love that.
It's got to go on a T-shirt somewhere. If this podcast ever becomes huge and we start doing stuff and gear, that's going to be shirt number 1.
That's great.
That's going to be the quote on this episode is Airway before self-actualization. I love that.
Always.
That's hilarious. So I've taken up way more of your time than I anticipated. So I have 2 last questions for you.
Okay.
One is, what's your definition of leadership?
Oh boy.
It's a tough one.
It kind of is. I mean, I can describe, I guess I could describe like what good leadership involves.
Okay.
Again, it involves a service orientation, service to the community, service to your staff, really being able to make decisions with the best outcomes for both, for patients first, and providing your staff with the ability to follow through on those decisions, right? It doesn't make a lot of sense if you make a leadership decision about what needs to happen in your department without providing your staff the resources that they need to make that happen, right? So the whole idea, take example of like hourly rounding, right? Which is like the big thing. I don't know, it may still be the big thing. Big buzz thing. The problem with that is I can't do that if I've got 10 patients.
Yeah.
It is physically impossible for me to go into a room once an hour and write something on a board.
Yeah.
When I've got 10 patients to take care of. So if you want these patients to be rounded on hourly, you need to provide us with the staffing to do that.
Yep.
So it's that kind of a thing. It's having a sense of what the unintended consequences might be of your decision, right? Because a lot of things that leaders decide are not inherently bad decisions. They're just unoperationalizable. I hadn't thought of that.
It's kind of funny. I'm adding that question, and the reason I'm adding that question is says like I told you, I just picked up a PRN gig, and leadership is their whole focus. Like that's what the first day of orientation was all about. You're a leader, whether you're the janitor or whether you're the CEO. You lead it.
Yeah, define that for me, please.
Yeah,
what is that actually?
And the way they put it, it wasn't bad. It really wasn't. It was actually one of the better orientations I went through. I was like almost pleasantly surprised. And I was like, that's a good question. That's a good question to ask people. And then the last question, what are 3 things a new leader should remember? And what are 3 things a new leader should forget?
I think that you need to remember that it's not about you. It's about your staff and your patients. I think that it's important to recognize that good decisions are not always popular decisions, but you really need to get as many people on board as you can. And 3 is you got to create a culture in which healthy challenge is possible. So the whole idea of a just culture is not only one that kind of recognizes the systemic factors in what happens in your department to patients and to staff, but it also creates an environment in which anybody can bring that concern forward, right? So again, whether you're the janitor or the tech or the manager, you should be able to have a discussion around patient safety issues, staff safety issues, like all of those things.
Yep.
Things to forget is that things you should forget is that, 1, it's all about you. Forget that. I think the idea that that leaders lead alone is something that people should abandon. Leadership is collaborative. Leadership is communal. And leadership should benefit everybody, really, in the most ethically stringent way possible. And then the last thing that you should forget is that dedication means applying every single brain cell of every single moment to your job. Like you actually do need to back off, allow space, take time off, that kind of stuff.
Absolutely.
Right? Like nobody cares. Like you're replaceable. You're completely replaceable. Everyone is. There is not a single person in the world who's not replaceable.
Yep.
So.
You're right. That was good. I like it.
Nice.
This was a lot of fun.
Yeah, well, I like chatting with you.
I love chatting with you. This has been incredible. This has been really, really good. And you've challenged my thinking on some stuff. I when I was just kind of listening to a little bit of the last recording we did, I was a couple times I was going, I've never thought of it that way, and I was like going, boy, you're like opening my eyes here. This is kind of cool.
Super.
I think that's awesome.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.